Today we're going to discuss cardiovascular disorders in pediatric patients. This is just a reminder that the heart normally received blood from the upper extremities, the head and the neck, and the lower extremities through the inferior vena cava and superior vena cava. This goes to the right atrium, and you have here the atrioventricular valves, which is tricuspid, and mitral as well. Those AV valves open in diastole, so receiving blood from the upper extremities and the lower extremities from the right atrium goes to the right ventricle in diastole. Then the valves close to have the semilunar valves, which are the pulmonary artery and the aortic valve, to open in systole, receive blood from the right ventricle to the pulmonary artery to be oxygenated to the lungs, and then receive back oxygenated blood to the left atrium, already oxygenated, to the left atrium, and then passes to the left ventricle via mitral valve. Okay, so once the blood is already in the left ventricle, this is expelled outside through the aortic valve in systole to the cisterna circulation. This is how normally the adult circulation blood flows through the heart. Then if you remember in health assessment, we had this distribution of volumes and pressure along with the effects that it will produce in the electrocardiogram. Let's review this a little bit. Remember that when the blood comes from the upper extremities, head and neck, and the lower extremities to the right atrium, the atrioventricular valves will open first to receive the blood from the atrium to the ventricles in diastole. As soon as the pressure falls in the right atrium and the left atrium, and the pressure increases at the level of the ventricles, this will shut down the atrioventricular valves, so they will close for the semilunar valves to open. The closure of the atrioventricular valves will start the first harsh sound, which is called S1. This closure and the opening of the aortic valve along with the pulmonary will give you, at the level of the EKG, ventricular contraction, which is no more than the depolarization and muscle contraction. Okay, so as the pressure will start increasing at the level of the ventricles, this will produce the closure again of the AV valves and the opening of the semilunar valves to have blood go to the pulmonary artery and the aorta to be oxygenated and also to be expelled to the cisterna circulation. So muscle contraction, defibrillation, QRS at the level of the EKG. Then you have semilunar valves to close and atrioventricular valves to open as soon as the ventricular pressure falls. So as the blood goes to the cisterna circulation and as the blood goes to the pulmonary artery to be oxygenated, there is decrease of pressure. This will shut down, close the semilunar valves, and this will start the second harsh sound, which is S2. So having S1 and S2 is a normal physiological sound heard in every patient, including adults and pediatric. So S1 is the closure of the AV valves, S2 is the closure of the semilunar valves. Okay, and then another cycle will start. Along with it, you would have the pressures of the jugular vein, internal jugular vein, which A demarcates atrial contraction and depolarization, and C will demarcate repolarization or relaxation. Okay? Now, let's discuss the fetal circulation and the changes that it entails. At birth, two main events affect the cardiovascular and the pulmonary system. One, the umbilical cord is clamped, removing the placenta from the maternal circulation. Then breathing starts. As a result, marked changes in the circulation occur. During fetal life, remember that placenta offers low resistance to blood flow. In contrast, the pulmonary arteries are markedly constricted and they're high resistance to blood flow in the lung. Therefore, the majority of blood entering the right side of the heart travels from the right atrium into the left atrium across the foramen ovale. You have here the foramen ovale. Okay, giving a right to left shunt in fetal circulation. In addition, most of the blood that makes its way into the right ventricle and then the pulmonary arteries will flow from the pulmonary artery into the aorta through the ductus arteriosus, giving you also a right to left shunt. Subsequently, pulmonary blood flow accounts for only 7 to 10% of the combined in utero ventricular output. At birth, pulmonary blood flow dramatically increases with the fall in pulmonary vascular resistance and pressure. The cause of prolonged high pulmonary vascular resistance include physical factors like lack of adequate air-liquid interface or ventilation, low oxygen tension, and vasoactive mediators such as elevated endothelin peptide levels or leukotrienes. This is very important because it's the mechanism of action of indomethacin for the closure of the patent foramen ovale. Clamping of the umbilical cord produces an immediate increase in resistance to flow in the systemic circuit. As breathing commences, the PO2 of the small pulmonary arteriole increases, resulting in a decrease in pulmonary vascular resistance, increased oxygen tension, rhythmic lung distension, and production of nitric oxide, as well as prostacyclin. Again, prostacyclin play a major role in the fall of pulmonary vascular resistance at birth. And again, this is one of the mechanism of action of how NSAIDs participate in the closure of this patent orifice once the child is born and they remain open. The pulmonary vascular resistance fall below that of the systemic circuit, resulting in a reversal in direction of blood flow across the ductus arteriosus and a marked increase in the pulmonary blood flow. Functional closure of the ductus arteriosus begins shortly at birth, and that could be a question of importance. The ductus arteriosus usually remains patent for 1 to 5 days. During the first hour at birth, a small right to left shunt is present. However, after the first hour, bidirectional shunting occurs, with the left to right direction predominating. In most cases, right to left shunting disappears completely by 8 hours. In patients with severe hypoxia, such as patients that have pulmonary hypertension, this could continue. Increased levels of PO2 of the arterial blood could cause spasm of the ductus. Although flow through the ductus arteriosus usually is gone by the 5 days of life, the vessel does not close anatomically for 7 to 14 days. In fetal life, the foramen ovale serves as a one-way valve shunting blood from the inferior vena cava through the right atrium into the left atrium. At birth, because of changes in the pulmonary and systemic vascular resistance, the increase in the quantity of blood returning from the pulmonary vein to the left atrium, the left atrial pressure rises above that of the right atrium, closing the foramen. This functionally closes the flap of the foraminal valve, preventing flow of blood across the septum. Persistent pulmonary hypertension is the clinical syndrome of full-term infants. The neonates could develop tachypnea, cyanosis, and pulmonary hypertension during the first 8 hours after delivery. These infants have a massive right-to-left shunting due to foramen valve being open. Because high pulmonary vascular resistance develop, these patients could progress to hypoxia and acidosis, and as well as sudden death. In the normal newborn, pulmonary vascular resistance and pulmonary arterial pressure continues to fall during the first week of life. As a result, demuscularizing of the pulmonary arterioles. Adult levels of pulmonary vascular resistance and pressure are normally achieved by 4 to 6 weeks of age. So today we're going to be discussing all the shunting mechanisms and also the defects associated with atrial septal defect, ventricular septal defect, and many other congenital anomalies that could lead to cyanotic or acyanotic symptoms. So in summary, once the baby is born, there's an increase. Once the baby is born, there is an increase of pulmonary blood flow. There is constriction of the ductus arteriosus. There is a shifting of pressure. Normally, in the fetal circulation, the right side has higher pressure than the left, and as soon as the baby is born, the pressure in the left side will be higher, the same as adults. Therefore, there's a functional closure of the foraminal valve and the ductus arteriosus in the first hour of life, and there is a decreased pulmonary vascular resistance by 6 to 8 weeks of life. Now, how is it important to obtain the history and physical on the pediatric patient? Remember that most congenital defects lead either to decreased pulmonary blood flow or to increased pulmonary blood flow with associated pulmonary congestion. So symptoms vary according to the alteration of this pulmonary blood flow. The presence of other cardiovascular symptoms such as palpitation, chest pain should be determined by history in the older child, and particularly attention should be made to if those symptoms are done in activity or rest, the onset and the termination of the symptoms, if it was gradual, if it was sudden, if it was precipitated by other factors. So chief complaint is super important. Prenatal, perinatal, and family history as well is important. In addition to that, the feeding patterns of the babies, if it's easily fatigued, if it's associated with edema, dyspnea or tachypnea, any cyanosis, any changes in growth development, any medication that the patient is taking. For example, you have to pay really close attention to physical examination in the general appearance. The examination begins with a visual assessment of the mental status. How is this baby interacting with the patterns? Any signs of distress? Any skin color changes? Document the heart rate, also the respiratory rate that we already discussed, the blood pressure in all 4 extremities. You will see when we talk about hypertension, how is it important to understand that you need to take blood pressure initially in all 4 extremities. Look for the oxygen saturation. Many congenital cardiac defects occur as part of the genetic syndrome. So complete assessment include also family history and any dysmorphic features. Look for the size of the baby by age. As I said, any level of consciousness changes. Any physical characteristics suggesting chromosomal defect, any cyanosis, any mottling or edema. As well, chest conformation should be noted in supine position, any precordial bulging that could indicate cardiomegaly. Temperature of the extremities, if the patient is diaphoretic. In addition, how is it interacting with the family? Is it fearful? Does it have anxiety signs? At level of palpation, before we go into the actual vital signs, you should look for any increased precordial activity, any lifting, any heaves. As you remember in health assessment, those are signs of cardiomegaly. Any thrill, any murmur that could be palpated, because remember, 4 and 5/6 or greater murmur could be palpated because they're associated with thrill. In auscultation, look for the first harsh sound. Remember that the first harsh sound is when the AV valves close. It is best heard at the lower left sternal border. It's usually medium pitch. The second harsh sound, remember, is when the semilunar valve closes. It is best heard at the upper left sternal border. And it has two components as S1. Remember that because in the newborn, the same as adult, the left side has higher pressure than the right side. It's always associated with closure of the left side valve first in a difference of milliseconds compared to the right. For example, if S1 is the closure of the AV valve, you're going to have a closure of the mitral first and then tricuspid. So you're going to have an M1 T1. And the semilunar, there's a closure of the aortic first and then the pulmonary. So you're going to have A2 P2. That is normal and it varies with inspiration. So splitting of S2 varies with respiration, widening with inspiration and narrowing with expiration. You could have abnormal splitting that could be indicative of cardiac disease as well. For example, a prominent or loud P2 is associated with the pulmonary hypertension. Now we're going to discuss the in another slide, the S3 and S4. But let's talk a little bit about heart rate, pulses, and blood pressure. The heart rate is very important to remember that it's done by auscultation in children younger than 10. So if the child is younger than 10 years old, the heart rate should not be palpated brachially or radially. It should be done by auscultation. The pulses, you have to check the pulses in all 4 extremities. Blood pressure should be taken annually at 3 years of age, and the initial assessment should be done in all 4 extremities. The pulse pressure, it doesn't have a major difference as in adult. A normal pulse pressure, remember that the pulse pressure is the difference between the systolic and diastolic. You get a medium, and that's the pulse pressure, and is normal between 20 to 50 millimeters of mercury. Cardiac rate and rhythm vary greatly during infancy and childhood, so multiple determinations should be made. This is particularly important for infants whose heart rate vary with activity. The rhythm may be regular or there may be normal phasic variations with respiration. For example, the resting heart rate of less than 1 month could be as low as 80 or as high as 160, and that is normal. 1 to 3 months from 80 to 200 2 to 24 months from 70 to 120, 2 years to 10 years of age from 60 to 90, which is very close to adulthood. Now, the best way to assess blood pressure is in sitting position. Palpate the brachial artery and place the index line of the cuff in line with the pulse. Rolling up shirt sleeve may act as a tourniquet and give a false blood pressure or pulse assessment. And remember, you should have more than 80% of the blood pressure cuff. That's basically for size. Now, in addition, let's talk about S3 and S4. Okay? So S3 is the sound of rapid left ventricular filling. It occurs in early diastole after S2 and is medium to low pitch. In healthy children, S3 diminishes or disappears when going from supine to sitting or standing. The majority of children have a normal physiological S3, means rapid and early left ventricular filling. Remember that in adults, that means that the volume that exerts the blood against the ventricle. So any distension of the ventricle, any dilation of the ventricle is pathological for S3. Is volume. S3 could be present in pregnant women and being physiologic. And because children, if you remember pharmacodynamics and pharmacology, because children have more water than lipid or muscle constitution, that is the reason why S3 is physiological present in children, but 65 volume overload or distension of the ventricle in adults and is pathological. S4 is pathological in all population. It's associated with atrial contraction and increased atrial pressure and has a low pitch similar to S3. It does occur before S1 and is heard in the presence of atrial contraction into a non-compliant ventricle, such as in hypertrophic, restricted cardiomyopathy, or even hypertension. Now, murmurs. Heart murmur is the most common cardiovascular finding leading to a cardiovascular referral. You have innocent or functional heart murmurs, which are very common, and those are 40 to 45% present in children, and have innocent murmurs at some times during childhood. You need to be able to know the location, radiation, intensity, which is always 1 over 6, 2 over 6, 3 over 6, 4 over 6, and so on. Variation with pulsations or positions, and innocence. So what are the characteristics? So location is where the murmur is best heard and where the sound extends. Okay. Relationship with the cardiac cycle and duration. If it's systolic or diastolic. If it's followed by S1 or not. If it's crescendo, decrescendo. If it's pansystolic. Intensity. Again, is grade 1 described as soft murmur, heard with difficulty. A grade 2 is soft but easily heard. Grade 3 is loud but without a thrill. Grade 4 is loud and associated with a precordial thrill. Grade 5 is loud with a thrill and audible with the edge of the stethoscope. And grade 6 is very loud and doesn't need to have a stethoscope on the chest to be able to hear it. We have a table for that. Quality. You need to know if it's harsh, musical, rough, if it's low pitch, high pitch, etc. If it varies with position, when the baby is supine or sitting or standing or squatting. If it's innocent. What are the innocent murmurs? Well, this is the grading that I already described. Grade 1, just audible with a good stethoscope in a quiet room. Grade 2, quiet but readily audible with a stethoscope. Grade 3, easy heard with a stethoscope. Grade 4 is loud, obvious murmurs with a palpable thrill. You start having a thrill here at the level of 4. Grade 5 is very loud, heard only over the pericardium but elsewhere in the body. And grade 6 is heard with the stethoscope off the chest. Now, before we continue, let's talk about the different innocent murmurs. You have the newborn murmur, which is heard in the first few days of life. This murmur is at the lower left sternal border without significant radiation. It's soft, it's short, it's vibratory, it's always 1 or 2 over 6, never 3 or more. Quality that often subsides with mild pressure if it's applied in the abdomen. Usually this appears by age 2 to 3 weeks. Then you have the still murmur. Is the most common innocent murmur of early childhood. It is typically heard between the 2nd and the 7 years of age of life. It is loudest midway between the apex and the lower left sternal border. The still murmur has a musical or vibratory short, grade 1, 2, sometimes rarely 3, early systolic murmur, and is loudest when the patient is supine. It diminishes or disappears with inspiration or when the patient is sitting. It's also loud when the patient has fever, anemia, any sinus tachycardia, or oxygen demand. What is a venous hum? A venous hum is usually heard after age 2. It is located in the infraclavicular area on the right side. It is continuous musical hum of grade 1 to 3 intensity over 6 and may be accentuated diastole and with inspiration. Why on the right side? Why in diastole? Why on inspiration? Because it marks the entrance of preload, the entrance of venous return to the right side. So you have a better return in inspiration, you have a better return on the right side, of course, because on the right side is when you get the blood from the superior vena cava and the inferior vena cava. Okay? And it's heard best on the right side in the infraclavicular area where exactly the right atrium is located. Turning the child neck, placing the child supine, and compressing the jugular vein obliterates the venous horn because you're obliterating venous return and preload. It's caused basically by turbulence at the confluence of the subclavian and the jugular vein. Now let's talk about briefly, I already posted a video presentation on the different type of cardiomyopathies, pericarditis, myocarditis, and endocarditis, but let's talk briefly a little bit about it again. Remember that hypertrophic cardiomyopathy is congenital, but it could also be acquired and is characterized by marked ventricular hypertrophy with diastolic dysfunction, not systolic, diastolic dysfunction, but without increased afterload. So for example, patients would not have valvular aortic stenosis, coarctation of the aorta, or systemic hypertension. Symptoms basically include dyspnea, chest pain, syncope, and sudden death. Etiology is basically a mutation. It's an autosomal dominant, and but it could be, again, acquired by acromegaly, pheochromocytomas, and even neurofibromatosis. If you remember, what I said is the most common form of pediatric population, the upper intraventricular septum. You see here the septum of the normal heart, and you see the thickness of the septum of the hypertrophic cardiomyopathy is thickened with little or no distension. This pattern is called asymmetric septal hypertrophy and appears to accelerate during puberty. So sometimes these patients don't have any symptom whatsoever in early childhood, and as soon as they start adolescency and they start in sports, they get the symptoms and even sudden death. During systole, the septum thickens, and sometimes the anterior mitral valve, already abnormally oriented and obliterated, okay, sucks towards the septum as a venturi effect, further obstructing the outflow tract and decreasing cardiac output. So contractility grossly is normal with the normal ejection fraction, but as result of hypertrophy, there is a stiff non-compliant chamber that resists to diastolic filling, elevating end diastolic pressure and increasing pulmonary venous pressure. So coronary blood flow therefore is impaired, causing symptoms of angina, syncope, cardiac arrhythmias. So basically, as I said, dyspnea, chest pain, syncope, and sudden death are the most common manifestation. They tend to have a systolic murmur increased by Valsalva maneuver and is typically present. The diagnosis is by echocardiography or by MRI, and the treatment again is beta blockers, verapamil, and sometimes, and most commonly in pediatric population, is due to myomectomy. So again, you could use beta blockers, you could use verapamil, you could use disopyramide. Patients with severe symptoms despite medical therapy and left ventricular outflow obstruction may require surgical myomectomy. Or you could do ablation therapy with ethanol, which is alcohol. Although dual chamber pacing has been used in children with good relief of obstruction, there's no significant improvement by research. Now let's talk about atrial septal defect. Basically, it's an opening in the interatrial septum causing left to right shunt and volume overload. Their classifications are ostium secundum, sinus venosus, and ostium premium. What happens is that after I explain the normal circulation of the neonatal, as soon as the baby is born, in atrial fibrillation, shunting is left to right initially. So let's come here first. Okay, you have a shunting because again there's a defect in the interatrium, so the foraminal valve remains open. Right? So because the pressures in the left side are higher than in the right side, the blood shifts from the left to the right initially. Some small atrial septal defect often just stretch patent foraminal valve close spontaneously during the first few weeks of life. Now persistent moderate to large defect result in a large shunt, leading to right atrial and right ventricular overload. So if all the blood from the left side shunts to the right side, you're going to have a right atrium and right ventricle volume and pressure overload. If unrepaired, these large shunts may lead to pulmonary artery hypertension, because where does your pulmonary artery come from? From the right ventricle. So if you have a right ventricle overload with volume and pressure, you're going to have pulmonary volume and pressure as well, increase in pulmonary vascular resistance and leading to right ventricular hypertrophy. Atrial arrhythmias will occur such as SVT, atrial flutter, atrial fibrillation. Ultimately, when the patient has pulmonary artery pressure and vascular resistance, now if the pressure increases as well in the right ventricle, you might have bidirectional shunting, which is called Eysenck-Menger reaction. The symptoms, most of the patients with small atrial septal defect are completely asymptomatic. Now, larger shunts may cause exercise intolerance, dyspnea on exertion, fatigue, arrhythmias, palpitations. There's passage possibly of microemboli across this defect, producing cerebral or thromboembolic events such as strokes. Rarely, when atrial septal defects is undiagnosed or untreated, then Asa-Menger syndrome developed, which is the bidirectional shunting and pressure. Auscultation typically reveals a very soft 2 to 3 over 6 mid-systolic ejection murmur. Fixed S2 at the left sternal upper border. If it's a large left to right shunting, may produce a low-pitch diastolic at the level of the tricuspid flow. So again, the majority of the murmurs that you would hear would be in the right side, so it will be tricuspid, because remember the shunting is from left to right, increasing pressure at the level of the right, and the only valves that you have at the level of the right will be the pulmonic and the tricuspid. Okay, now how do you diagnose? Basically by cardiac examination, echocardiography, and EKG. So with significant shunting, since you have right ventricular hypertrophy, you're going to have a right axis deviation. So you would have as well bundle branch blocks, right bundle branch. Chest x-ray shows cardiomegaly basically on the right side based on the right ventricle, which show increased pulmonary vascular markings of pulmonary hypertension. Cardiac catheterization is usually not needed. And treatment, if the patient is asymptomatic with a small shunt, only requires observation and periodic echocardiograms. If it's moderate to large and there's evidence of right ventricular volume overload on echocardiogram, then, and if the child is between 2 years and 6 years of age, then repair by surgery. How do you do that? By transcatheter closure, which are called either Gore helix or septal occluder or Amplatzer. So surgical repair is the best for them. Always endocarditis prophylaxis. Now, ventricular septal defect is an opening in the interventricular septum. Now, it's not in the atrium, it's in the ventricles, causing a shunt between the ventricles. You also have a classification here. Could be perimembranous, could be trabecular, could be subpulmonary or inlet. Perimembranous is the most common. It's 70 to 80% of the defect in the ventricle. It's very close to the tricuspid valve. And trabeculars are 5 to 20%. Subpulmonary is 5 to 7%, and inlet are very, very mild, 5 to 8%. The magnitude of the shunt depends on the defect size and the resistance to pulmonary outflow. Blood again flows. Let me show you. Since the left side is higher pressure compared to the right, the blood always flows from the left to the right. So the shunting will be left to right shunting. So easily cross from the left to the right in largest defect, which are thus called non-restrictive pressure. As soon as the pressure equalizes, as I explained you before in ASD, then you have bidirectional and Asa-Menger syndrome. Assuming that there's no pulmonary stenosis, because it could be associated with it, a large shunt causes pulmonary hypertension, elevated pulmonary artery pressure, pressure overload, and right ventricular hypertrophy, the same as ASD. Symptoms depend on the defect size and the magnitude of the left to right shunt. Children with small ventricular septal defect are completely asymptomatic and they grow and develop normally. In children with large defect, you're going to have symptoms of heart failure and right-sided heart failure more. Respiratory distress, poor weight gain, fatigue after feeding, edema, changes of level of consciousness that appears at age 4 to 6 weeks when pulmonary vascular resistance normally falls at that age. Auscultatory findings If it's small, typically produce murmurs ranging from 1 to 2 over 6, high pitch, short, systolic murmurs. And if it's large, it would be 3 to 4 over 6 hollow systolic murmur. Moderate to large ventricular septal defect produce a hollow systolic murmur that is present at age 2 to 3 weeks already. Patients would have tachypnea, dyspnea with feeding, failure to drive, gallop, crackles, hepatomegaly, even though the right side failure is more predominant. Diagnosis, again, by chest x-ray or echocardiogram. Diagnosis is suggested by clinical examination, supported by the chest x-ray and EKG. What you will find is cardiomegaly, increased pulmonary vascular markings, EKG because the right side is more volume and pressure overloaded, right ventricular hypertrophy and right axis deviation. Two-dimensional echocardiogram basically establish the diagnosis. You will be able to see the defect. Treatment, if it's small ventricular septal defect, often closes spontaneously during the first few years of life. Larger defects are less likely to close spontaneously. So you treat based on volume overload with diuretics, with digoxin and ACE inhibitors may be useful before cardiac surgery as well. Or surgical treatment, repair. In addition, remember that you could use the indomethacin, even though it's not the best for this type of closures. This is again treatment. Children with larger defect, you would have what I just said: respiratory distress, poor weight gain, fatigue after feeding. A small defect will produce a murmur grade 1 to 2 over 6, and even higher and hollow systolic when the defect is bigger. You need to do serial cardiac catheterizations to be able to show that the actual shunt is smaller. And in asymptomatic patients that have no symptomatic or evidence of pulmonary hypertension, being followed by cardiologists. Remember that if it's small, may close spontaneously over time. Tachypnea, poor feeding, diaphoresis. If you're going to do surgery, try to do surgery before age 2 years old to prevent pulmonary hypertension. And again, these are the symptoms that patients might entail. If it's large and symptomatic, surgical repair and control the symptoms before with diuresis, digoxin, and ACE inhibitors. You could also do a pericardial patch by 3 to 6 months of age. And cardiac catheterization is never the preferred method for closure. Okay? Surgery is. Now let's talk about patent ductus arteriosus. Is persistence of the fetal connection. Remember, you have the ductus arteriosus, which is between the aorta and the pulmonary after birth, resulting in also left to right shunt. There's always left to right shunt in acyanotic congenital heart diseases because there is always a high pressure at the level of the left side, heart side, compared to the right. So the left atrium and the left ventricle and the aorta would have a higher pressure compared to the right atrium, right ventricle, and the pulmonary artery. So that's the reason why it tends to be constantly from left to right. So remember, that's the normal connection. It is necessary for proper fetal circulation, but at birth, the rise in pulmonary artery oxygen pressure and decline in prostaglandin concentration causes closure of the ductus arteriosus, typically beginning within the first 10 to 15 hours of life. It is normal process and physiological consequence depending on ductal size. Small ductus rarely cause symptoms. A large ductus causes a large left to right shunt. Over time, a large shunt results in left heart enlargement. There's pulmonary artery hypertension and elevated pulmonary vascular resistance. So whenever you have left to right shunt, your right side is going to be congested and high pressure. You're going to have pulmonary hypertension and all the symptoms of it, right side or heart failure. Okay, so these symptoms would be first, you're going to have continuous machinary type murmur, bounding peripheral pulses if large ductus is present. There's a presentation and course depending on size of the ductus and the pulmonary vascular resistance. Clinical features of large ductus are failure to drive, tachypnea, and diaphoresis with feed. Left to right shunt with normal pulmonary vascular resistance could also occur. So infants and children with a small PDA are generally asymptomatic, but with the large PDA, they show signs and symptoms of heart failure that in the child will be failure to drive, poor feeding, tachypnea, dyspnea with feeding, tachycardia, and edema. Premature infants may present with respiratory distress, apnea, worsening mechanical ventilation requirements, and other complications such as ischemic bowel, necrotizing enterocolitis. Signs of heart failure occur early in premature infant than in full-term infant and may be more severe, of course. A large ductal shunt in a premature infant often is a major contributor to the severity of the lung disease. Most children with small PDA have a normal heart sound, but they could present with a grade 1 to 3/6 continuous machinary murmur and is heard best in the upper left sternal border. The murmurs stand from systole to beyond the second heart sound. Full-term infant with a significant PDA shunt have full or bounding peripheral pulses with a wide pulse pressure greater than 50. A grade 1 to 4/6 continuous machinary murmur is characteristic. They could also have a hyperdynamic precordium present. How do you diagnose? By echocardiography. And what else? Clinical examination, chest x-ray, treatment. Because the decrease of prostaglandin will help or promote the closure of the ductus arteriosus, you should give a prostaglandin synthesis inhibitor, which is indomethacin or ibuprofen. That helps in premature children with the closure of the PDA. Sometimes transcatheter occlusion devices or surgical repair is necessary. So in premature infants with compromised respiratory status, the PDA can sometimes be closed by using prostaglandin synthesis inhibitors such as indomethacin or ibuprofen. Fluid restriction may facilitate also ductal closure. If not, then ligation with the surgical repair. In full-term infants, indomethacin is usually ineffective, so you should do transcatheter closure. That's the standard of care in children more than 1 year old and premature. Now, we're going to be discussing now cyanotic heart diseases. So we already discussed acyanotic. So cyanotic heart diseases entail transposition of great vessel, Tetralogy of Fallot, tricuspid atresia, aortic stenosis, pulmonary stenosis, and coarctation of the aorta. So briefly, let's talk about transposition of great vessels. This basically is everything backwards, where you're having right side, which is right atrium and left and right ventricle, the main arteries that goes out from the right ventricle is the pulmonary artery, but instead you have the aorta. And in the left ventricle, instead of the aorta, you have the pulmonary artery. So everything's backwards. So transposition of the great vessels occur when the aorta arises directly from the right ventricle instead of the left ventricle, and the pulmonary artery arises from the left ventricle instead of the right ventricle, resulting in independent, parallel pulmonary and systemic circulation. Oxygenated blood cannot reach the body except through opening connecting the right and the left side. For example, you must have a patent foraminal valve or ventricular septal defect in order to have oxygenated blood to reach the systemic circulation. So, systemic and pulmonary circulations are completely separated and backwards. After returning to the right heart, the saturated systemic venous blood is pumped into the systemic circulation without being oxygenated in the lung. Oxygenated blood entering the left heart goes back to the lung rather than the rest of the body. This anomaly is not compatible with life unless the saturated and oxygenated blood can mix through opening such as atrial septal defect, ventricular septal defect, etc. Severe cyanosis occur within the first hour of birth, followed by rapidly metabolic acidosis secondary to tissue hypoperfusion. Patients with a large ventricular septal defect or patent ductus arteriosus or both are less cyanotic, but symptoms and signs of heart failure, again, tachypnea, dyspnea, tachycardia, diaphoresis, inability to gain weight, etc., may develop during the first week of life. Except for generalized cyanosis, physical examination is rather unremarkable. Heart murmurs may be absent unless associated with an S2. Diagnosis is by echocardiography. It has to be suspected if the baby is cyanotic at birth. And treatment is basically, again, by prostaglandin inhibitors, balloon atrial septostomy, and surgical repair of the vessels. For severely hypoxemic neonates who do not immediately respond to prostaglandin or who have a very restrictive foraminal valve, cardiac catheterization and balloon atrial septostomy, which is called Rashkind procedure, can immediately improve systemic saturation. Balloon-tipped catheter is advanced into the left atrium through the patent foraminal valve, then is inflated, and a radial opaque dye is injected into the opening. Definitive repair is the arterial switch, which is called Jatene operation, Jatene operation. This is typically done during the first week of life. Now let's talk about Tetralogy of Fallot. This basically consists of 4 fissures. You have large ventricular septal defect, right ventricular outflow tract, pulmonary valve obstruction, right ventricular hypertrophy, and overriding of the aorta. The ventricular septal defect is typically large. Systolic pressures in the right and the left ventricle are the same. Pathophysiology depends on the degree and right ventricular outflow obstruction. A mild obstruction may result in a left to right shunt through the VSD. A severe obstruction causes right to left shunt, resulting in low systemic arterial saturation and cyanosis that is unresponsive to oxygen. In some children with unrepaired tetralogy of Fallot, most often those several months up to 2 years of age, sudden episodes of profound cyanosis and hypoxia, which are called TET spell, may occur. A spell may be triggered by an event that slightly decreases oxygen, such as crying or even defecated, that suddenly decreases systemic vascular resistance. If they're playing, they're kicking, or if any playful event or insult may suddenly produce tachycardia and hypovolemia. The mechanism of a TET spell remains uncertain, but several factors are probably important in causing an increased right to left shunt and a fault in arterial saturation. Factors include increased right ventricular outflow, increased pulmonary vascular resistance, um, hyperpnea, and increased adrenergic tone. There is increased catecholamines release and contractility and outflow obstruction. The symptoms, again, look at the TET spells, severe cyanosis and dyspnea with feeding and poor weight gain. This, remember, may be precipitating the TET spells by crying, by respiration, by anything. A severe spell may lead to seizures and occasionally death. During play, some toddlers may intermittently squat, a position that increases systemic vascular resistance and aortic pressure, which decreases the right to left shunt and raises oxygen saturation. So this is the reason why they squat, because that increases systemic vascular resistance and decreases the shunting. Auscultation detects a very high grade 3, even 5 over 6 systolic murmur at the left mid-upper sternal border. The murmur in tetralogy is always due to pulmonary stenosis. The ventricular septal defect is silent because it's large and has no pressure gradient. Diagnosis is also by echocardiogram, but chest x-ray and EKG could reveal pulmonary artery vascular congestion, EKG right ventricular hypertrophy. Cardiac cath is rarely needed. Treatment for symptomatic neonates, you could give prostaglandin inhibitors. For TET spells, positioning, calming, oxygen, and some drugs that I will describe, and also surgical repair. So for the TET spells, are treated by placing infants in a knee chest position. Older children could squat because that relieves the systemic vascular resistance and pulmonary artery and at the level of the aorta and decreases the shunt. Establishing a calm environment, giving oxygen. For medical therapy, you could give morphine, you could give IV fluid for volume expansion, you could give sodium bicarbonate, propranolol can be given as well, ketamine, and also complete repair is the definitive treatment. And patching closure of the ventricular septal defect, widening of the right ventricular outflow tract by muscle resection and pulmonary valvuloplasty. In some neonates with low birth weight, initial palliation may be preferred to complete repair. Perioperative mortality is really high. Endocarditis prophylaxis, don't forget that, to all the congenital heart diseases. Now let's talk about tricuspid atresia. It's basically the absence. Atresia is no present of the tricuspid valve, which is accompanied by a hypoplastic right ventricle. So if you have no, this is the right atrium, this is the right ventricle, and there's no tricuspid valve at all. You have the mitral, you have no tricuspid. What happens is that infants with decreased pulmonary blood flow usually have mild to moderate cyanosis at birth, which increases sometimes dramatically over the first several months of life. There is associated anomalies that are common and has to include ventricular septal defect or patent ductus arteriosus. Physical examinations usually detects a single second heart sound, grade 2 over 3, holosystolic. There's a systolic ejection murmur as well in the pulmonary level, there is patent ductus arteriosus that may be present. So the only way to have this patient survive is to have, since there is no tricuspid valve at all, you must have a connection between the right atrium and the left atrium, and then going into the left ventricle and to systemic circulation. So therefore, you must have either atrial septal defect or patent ductus arteriosus to be able to survive this defect. Diagnosis again is by echocardiogram, chest x-ray, and EKG. Chest x-ray shows normal or slightly increased heart size, right atrial enlargement, and decreased pulmonary vascular markings. The cardiac silhouette sometimes resembles the Tetralogy of Fallot, but not necessarily is associated by the same defects. It has a boot-shaped heart and concave pulmonary artery segment. Pulmonary vascular markings may increase sometimes with cardiomegaly in some infants when they have transposition of the great vessels associated. You have a left axis deviation in the EKG. Cardiac catheterization may be necessary before surgery. And treatment for severe cyanotic neonates, you must give prostaglandin inhibitors, balloon atrial septostomy, and basically the repair of the absence of the valve is needed. Endocarditis prophylaxis, don't forget. Now let's talk about aortic stenosis. It's basically a narrowing of the aortic valve, obstructing the blood flow from the left ventricle to the ascending aorta during systole, and of course to the systemic circulation. Causes could include congenital bicuspid valve, idiopathic degenerative sclerosis with calcification, rheumatic fever, aortic stenosis is basically 60% of patients of the population that have it. There's increased pressure load imposed by aortic stenosis results in compensatory hypertrophy of the left ventricle without cavity enlargement. With time, the ventricle can no longer compensate, causing secondary left ventricular hypertrophy, reduced ejection fraction, decreased cardiac output. Patients with other disorders may have as well myocardial infarction, intrinsic cardiomyopathy. Signs and symptoms in adults, you know that is basically due by low cardiac output, which includes syncope, chest pain, so anything that relates to ischemia, because there is decreased blood flow to the systemic circulation. In pediatric patients, the same. Patients might complain of palpitation, dizziness, but most of the patients are completely asymptomatic. In addition, patients could have a mid-systolic click, and it's elicited best in standing position, and that's the hallmark of this entity. Imaging, most chest x-rays are completely normal and not usually indicated. EKG could be completely normal or with signs of hypertrophy, which are increased R wave as well as S. Echocardiography basically shows a significant posterior systolic movement of the mitral valve, degree of stenosis of the aortic valve. Treatment, um, besides surgical repair, the treatment could be targeted to symptoms of ischemia, which are exactly the same as angina and MI. So for severe or symptomatic aortic stenosis in the newborn, you should do valvotomy, which is the actual opening up of the valve. For older children, aortic valve replacement with mechanical or bioprosthetic valves, always with anticoagulation therapy. In addition, propranolol may be effective in the treatment of coexisting arrhythmias. Don't forget the prophylaxis of endocarditis. So basically what you have is harsh systolic ejection murmur at the upper right sternal border, ethereal systolic click, and dilation of the ascending aorta. Now let's talk about coarctation of the aorta. Is localized narrowing of the aortic lumen that results in upper extremity hypertension, left ventricular hypertrophy, and malperfusion of the abdominal organs and lower extremities. Coarctation of the aorta usually occurs at the proximal thoracic aorta, just beyond the left subclavian artery and before the opening of the ductus arteriosus. Coarctation rarely involves the abdominal aorta. Thus, in uterus and before the patent ductus arteriosus closes, much of the cardiac output bypasses the coarctation via the PDA. Coarctation may occur along or with various other congenital anomalies such as ventricular septal defect, aortic stenosis, and patent ductus arteriosus. There is pressure overload in the arterial circulation proximal to the coarctation, and there is hypoperfusion distal to the coarctation. So pressure overload causes left ventricular hypertrophy and hypertension in the upper part of the body, including the brain. And hypoperfusion affects the abdominal organs and lower extremities. So there's a difference in pressure. Ultimately, the pressure gradient increases collateral circulation of the abdomen and lower extremities via intercostal, mammaria, and other arteries. Symptoms. So let's continue with the aortic stenosis, which is associated with coarctation of the aorta. They're going to have a crescendo, decrescendo ejection murmur. This is unique of aortic stenosis, crescendo, decrescendo. Okay, remember that the symptoms of aortic stenosis, as same as coarctation, you're going to have syncope, angina, and dyspnea. There is a heave due to left ventricular hypertrophy, and you will have widening of the P2 associated with S1 accentuated. Okay, so the aorta here will be completely stenotic. Okay, so signs and symptoms, if coarctation is significant, of course, there's no blood supply or poor to the systemic circulation, having circulatory shock with acute renal insufficiency with oliguria and anuria, and metabolic acidosis due to ischemia. Other signs and symptoms could include sepsis. In the infant with critical severe coarctation are likely to become acutely ill as soon as the ductus arteriosus constrict. Less severe coarctation could be completely asymptomatic in infants. Sort of symptoms could include headache, chest pain, fatigue, claudication during physical activities. This is pathognomonic. Upper extremity hypertension with lower extremities decreased pressure. Often present heart failure signs and symptoms. Typical physical findings include strong pulses and hypertension in the upper extremities and diminished or delayed femoral pulses and BP gradient decrease in the lower extremities. You could also hear 2 to 3/6 systolic murmur that is best heard at the upper left sternal border that radiates to the axilla and sometimes most prominently in the left interscapular area. You diagnose this by echocardiogram, CT or MRI angiography, and the treatment again is for symptomatic neonates require cardiopulmonary stabilization and infusion of prostaglandin inhibitors. In addition, you should give diuretics for volume overload. If you have any increased pulmonary vascular resistance, you could give inotropes to improve cardiovascular contractility with dopamine, dobutamine, and milridone. In non-emergency situations, patients with hypertension, you should treat the same as hypertension, beta blockers, ACE inhibitors. After repair of coarctation, hypertension may persist or develop years after repair. And again, you treat the same with beta blockers, ACE inhibitors, angiotensin II blockers, or calcium channel blockers. The preferred definitive treatment is controversial. Some centers prefer balloon angioplasty with or without stent. And some others basically patch aortoplasty with the left subclavian flap aortoplasty as well. Now, let's talk about Kawasaki. Kawasaki is basically a vasculitis. Sometimes involves the coronary artery that tends to occur in infants and children between 1 year to 8 years of age. It's characterized by fever, rash, conjunctivitis, mucous membrane inflammation, and lymphadenopathy. Coronary artery aneurysm may develop and rupture and cause myocardial infarction. So Kawasaki is the vasculitis of the medium-sized artery, most significantly the coronary artery, which are involved in about 20% of untreated patients. It's the leading cause of acquired heart disease in children. 80% of children are less than 5 years of age. Median age is 2, and male to female ratio is more females than male. More males than females. The etiology is unknown, but the epidemiology and clinical presentation suggest an infection or an abnormal immunological response to an infection in genetically predisposed children. Look always for autoimmune diseases, which are the possibility. Okay, 80% of patients again are diagnosed less than 5 years of age. Cases in adolescents and adults also could occur year-round, but is most often present in spring and winter. The signs and symptoms, the illness tend to progress in stages, beginning with fever that lasts at least 5 days, usually remittent. However, unless treated with antipyretic, temperature does not return to normal. It's greater than 102 and is associated with irritability, lethargy, intermittent colically abdominal pain, usually within a day or two of fever onset. Bilateral bulbar conjunctival injection or conjunctivitis appear without any type of exudate. Within 5 days, an erythematous macular rash appears, primarily over the trunk, with accentuated in the perineal region. So it could occur in the trunk and the perineum. The rash may be morbilliform urticaria with the pattern of erythema multiforme. It is accompanied by pharyngitis, red dry fissure lips, and red strawberry tongue. This is pathognomonic. During the first week, pallor of the proximal portion of the fingernails, like leukonychia, may occur. Erythema or purple-red discoloration and edema of the palms and soles usually appear about the 3rd to 5th day of life. Tender non-suppurative cervical lymphadenopathy could be present. The illness may last 2 to 12 weeks long. Other non-specific signs could include arthritis or arthralgias, meningitis, hepatitis, diarrhea, vomiting, etc. Cardiac manifestations usually begin in the subacute phase of the syndrome, which is about 1 to 4 weeks after the onset of rash, fever, and other early acute clinical symptoms. So the diagnostic criteria is fever more than 5 days plus 4 of the following: bilateral painless conjunctivitis, lip or oral cavity changes such as cracked lips, strawberry tongue, and inflammation of the mucosa, cervical lymphadenopathies unilateral, exanthema multiforme or polymorphous, which is the rash, mobiliform, extremity changes such as red swelling of the hand and the feet with subsequent dequamation. So you need to have fever more than 5 days plus 4 of the following. In addition, I have another one, which is CREAM, an acronym on, which is conjunctivitis, R for rash, E for edema of the palm and soles, A for adenopathies, and M for mucosa involvement. This is basically the algorithm for treatment and diagnostic values. Basically, is by the clinical criteria that we already discussed. Some febrile children who have fewer than 4 of the 5 diagnostic criteria nonetheless develop vasculitic complications. So children are considered to have an atypical presentation, but just have that in mind. Before we go through the algorithm, laboratory tests are not diagnostic but may be done to exclude other disorders. You could do CBC, ANA, rheumatoid factors, set rate, and even throat cultures. Leukocytosis, often with a marked increase in immature cells or shift to the left, is commonly present. Anemia with normocytic normochromic, thrombocytosis could be present. Liver enzymes, elevated proteinuria, etc. So you have fever for more than 5 days, and here says 2 to 3, but it's actually 4 or more in the clinical criteria. So if yes, is it consistent with Kawasaki? Assess laboratory data. Do the set rate or the CRP marks. Follow daily. Fever continues for 2 days, or does the result? If it continues for 2 days, continue assessing the possibility of the criteria and treat as such. If the fever resolved and there is no peeling, no follow-up is needed. If peeling occurs on the hand and the soles, do an echocardiogram for possible carditis complications. If the set rate is more than 40, then do an echocardiogram. If the echocardiogram is negative and the fever persists, repeat the echocardiogram and consult the experts with the pediatric cardiologist. If the echocardiogram is positive for carditis, then treat. If there is supplement criteria, then do an echocardiogram. If the fever persists, continues assessing for possible Kawasaki. Complications are myocarditis, pericarditis, valvulopathies, aneurysms. So this is why it's so important to do these follow-ups. A diagnosis, an EKG, and an echocardiogram must be done because abnormalities may not appear until later. These tests are repeated 2 to 3 weeks interval, then 6 to 8 weeks interval, and perhaps even more 6 to 12 weeks after the onset. EKGs may show arrhythmias, decreased voltage, left ventricular hypertrophy. Should detect echocardiogram any type of coronary artery disease, aneurysm, pericarditis, or myocarditis. The prognosis without therapy, the mortality is 1%. It sounds low, but it's very significant for pediatric population, usually occurring at 6 weeks of onset. With adequate therapy, the mortality drops to 0.17. So, treatment, high dose of IV immunoglobulin, IG, IV, and high dose of aspirin. Children should be treated by in close consultation with an experienced cardiologist, pediatric infectious disease, and pediatric rheumatologist. Because infants with atypical Kawasaki are at high risk for coronary artery aneurysm, treatment should not be delayed. Start with IV immunoglobulin and aspirin at high dose. Aspirin dose is reduced to 3 to 5 milligrams per kilogram when the febrile event has subsided. Most patients have a brisk response in the first 24 hours. Small fraction continues to be ill with fever for several days. After the child's symptoms has abated for 4 to 5 days, decrease the dose of aspirin. Children with giant coronary aneurysm may require additional anticoagulation therapy with Coumadin. Again, small risk of Ray's syndrome exists in children receiving long-term aspirin therapy during outbreaks of influenza or varicella. I know it's a caution, but this mortality is higher than the mortality for Ray's syndrome, so do not hesitate to start aspirin on patients that have Kawasaki. Now let's talk about hypertension. Hypertension, is basically high blood pressure that you have essential and secondary hypertension. Remember that hypertension is no more than primary idiopathic, that is a result of the activation of the renin-angiotensin-aldosterone cascade or RAS system. Every pediatric patient should have blood pressure measurement at age 3. Okay, and it's based on percentiles. So I'm going to explain and separate the guideline for hypertension in pediatric population or face-to-face in class. If blood pressure is greater than 95% with measurement weekly over a 2 to 4 week period. Causes, again, could be primary, could be secondary associated with diabetes type 1, secondary to pheochromocytoma, to Cushing syndrome, etc. And again, I'm going to explain the guideline for hypertension either in a video presentation or face-to-face in class. Let's talk about chest pain. Chest pain is a very common complaint, even more in pediatric population. Many patients are well aware that this is a warning and potential life-threatening disorder. It's very common and accounts for 6 to 1,000 visits in the ER and urgent care. It's rarely organic in nature. Although children with chest pain are commonly referred for cardiac evaluation, chest pain in children is rarely cardiac in origin. Have that in mind. Other more likely causes include reactive airway disease, musculoskeletal pain, esophagitis, gastritis, and functional pain. Detailed history and physical examination should guide you to the appropriate workup of chest pain. Rarely is there is a need for laboratory test or evaluation. Look for the location, intensity, radiation, and changes with position. Always try to palpate the chest wall because one of the most common causes of chest pain in pediatric population is triggered by musculoskeletal diseases. For instance, if the chest pain is followed by exertion, may lead to a more elaborate evaluation for cardiac disorder. The timing of pain in relation to meals may suggest gastrointestinal cause. The patient should also be asked about how pain relief is achieved, social history to relieve any psychological stressors, even in the family, if they're smoking next to the child. On physical examination, again, must pay attention to the vital signs, chest wall musculature, cardiac, pulmonary, and abdominal examination. Look for the majority of other causes because in the pediatric population, the most common cause is musculoskeletal. It's rarely cardiovascular. Again, cardiac diseases are a rare cause of chest pain. Children may mistake palpitations for chest pain. Structural cardiac lesions are rare. If suspect underlying cardiac disease, then you should refer to the cardiologist. Then let's talk about syncope episode. Syncope in pediatric population and in any other patient is a sudden transient loss of consciousness that resolves spontaneously. The common form of syncope occurs in 15% of children and is a disorder of control of heart rate and blood pressure by the autonomic nervous system that causes hypotension and bradycardia. It is often with rapid rising of postural hypotension, prolonged standing, or hypovolemia. Patients exhibit vagal symptoms such as pallor, nausea, and diaphoresis. It's also called an autonomic dysfunction. The patient is placed supine on a tilt table. That's one of the tests for examination. Syncope is usually self-limit. Can recur over approximately 6 months to 2 years and can be controlled with either dietary salt or volume expansion to prevent hypovolemia. In refractory cases, medications to manipulate autonomic nervous system can be used. For example, any mineralocorticoids such as fluorocortisone that causes renal salt reabsorption, and those increases intravascular volume. In addition, you could use beta blockers or vagolytic such as disopyramide that help control the hypervagotonia, and this is a selective serotonin reuptake inhibitor that is used to alleviate the symptoms of syncope. Always look for any stress in the family, any history of underlying arrhythmias in the family of this child. Now, how do you provide clearance for cardiac sports? By cardiovascular history. If there is no, for example, major congenital anomaly that could impair oxygen supply, any routine use of EKG and echo, you must do before clearing the patient, and also by guidelines that we will discuss. In addition, remember that sudden cardiac death, including hypertrophic cardiomyopathy, is the leading cause of death in this population. Is up to 75%. Okay, and any athlete with cardiovascular symptoms require further evaluation before you clear them for sports. Now, what is heart failure? Heart failure is basically that the heart fails to meet the circulatory and metabolic needs of the body. It could be the same as the adult, volume or pressure overload. So you could have right-sided heart failure, you could have left-sided heart failure. Right ventricular failure in the pediatric population could be due by aortic septal defect, atrial septal defect or pulmonary insufficiency, abnormal pulmonary venous return or pulmonary hypertension or pulmonary stenosis. On the contrary, left is everything related to the left side, such as ventricular septal defect, patent ductus arteriosus, aortic insufficiency, aortic stenosis, coarctation of the aorta, etc. Heart failure is the clinical condition in which the heart fails to meet the demand. So it's not always significant to or related to exercise intolerance and fatigue, because patients could have right-sided heart failure that result from volume overload as well in the right side. Abnormalities in the right ventricle also could entail any, for example, tricuspid atresia that we already discussed. As a result of elevated pressures and volume, there is impaired relaxation of the left ventricle, and the left heart can lead to failure. and the right side as well eventually. Remember that you have first left left heart-sided heart failure, and then the right unless there is a primary pulmonary hypertension. The signs and symptoms are exactly the same. If you have right-sided heart failure, you would have alteration of level of consciousness, you would have jugular vein distension, you would have GI discomfort and poor feeding and ascites and peripheral edema. And if you have left-sided heart failure, you would have shortness of breath, you would have dyspnea on exertion, and also pulmonary edema. So treatment, before we go here, the therapy basically is directed towards the underlying cause, regardless of the etiology. Remember that neurohormonal activation of the RAS system occurs early when ventricular systolic dysfunction is present. So remember that what is triggered first is catecholamines being increased. So increasing levels of epinephrine and norepinephrine, so you should blunt that with beta blockers. In addition, the activation of the renin-angiotensin aldosterone system, you could treat that with ACE inhibitors and ARBs. Any salt and water retention could be treated with diuretics as well as aldosterone antagonists. The gold standard diagnostic or therapeutic approach, there's no gold standard diagnostic or therapeutic approach in children. It's exactly the same as in adult. Treatment must be individualized and therapies should be aimed at improving cardiac performance. Okay, so if you have any type of patient that have CHF, outpatient, you would reduce the afterload only by ACE inhibitors and ARB. You will reduce preload by fluid restrictions and diuretics. You will reduce catecholamines released by beta blockers. You will reduce also volume overload by aldosterone antagonist. You would give ionotropicity by digitalis. In addition, you reduced afterload inpatient with milridone, nitroglycerins, or inotropes with dopamine and dobutamine. And finally, if there is no, if there is failure of the medications, mechanical circulatory support by ECMO. So what you should ask to be able to have an idea what the symptoms are of the patient. How is the feeding? Does the baby tire out? When feeding? Does the baby changes color during feeding? That tells you that the patient is short of breath. Is the baby growing? Having poor growth development is a sign of ischemia and blueness like cyanosis. Children, do you feel short of breath when exercising? Are exactly the same questions that you ask the adult. Do you feel short of breath when laying down, having orthopnea or paroxysmal nocturnal dyspnea? Does your hand or feet get cold because of edema? Do you feel sweaty? And to the patterns as well, how is the level of activity? If they feel tired, if they have edema or any type of cyanosis, and we already covered this. I also have the guideline for CHF that I will add, and remember that I already discussed the infective endocarditis as a guideline separate. So if you look, there's no difference in treatment for the pediatric patient. It's the same as the adult, vancomycin or any beta-lactam antibiotic with or without gentamicin for 6 weeks. And remember, who do you give antibiotic prophylaxis for endocarditis? In adult, is to every single bleeding exposure diagnostic procedure. In pediatric population is for prosthetic cardiac valve, any prior episode of infective endocarditis, if the patient has a congenital heart disease, if the patient is getting a palliative cyanotic heart disease, or any post-procedure 6 months after, if there is any implantable prosthetic material, or after cardiac transplant. And this is the end of this presentation, and coming would be guidelines and face-to-face discussion in class with case studies.